All right. Good morning, everyone. This is Dr. Michael K from the Center for Functional Health, and I've been looking forward to this conversation with Carole Gross. She is a pelvic floor physical therapist, and today we're going to cover a lot of great topics. So, Carole, welcome, welcome. It's great to have you aboard.
Thank you.
So, for those who are watching, if you can share your background and share like how you got into pelvic floor physical therapy, because when we usually think of physical therapy, most people think of like, oh, we gotta help somebody with balance or a hip or a shoulder, but there's way more to physical therapy than just that. So, if you can share with us how did your journey begin?
So I went to Thomas Jefferson University and I graduated in their first master's class back in 1992. And then I had worked with pediatrics and aquatics and orthopedics, outpatient orthopedics, rehab, acute care. And then in the early, like about 2013, I was dealing with oncology issues of my own. And I was too weak to be able to work, but my brain was still working. So I decided to go back for my doctorate at that point. And when I did, I completed that in 2015 through Arcadia University. And um, I knew I was supposed to be doing something else. So had been doing home care and loved it, and decided that I felt like I was being called to do something, but I wasn't sure what it was. So out of the blue, a friend called me and asked me to go to a retirement party. I decided to go last minute after I dropped my daughter off dancing, and I bumped into an old friend that had a pelvic health clinic, and so she says, "Why don't you guys well, why don't you just come visit us?" And so I stopped in and I walked through the door and I'm like, "I'm home. Like this is where I was supposed to be." So anyway, it was at the perfect time during the curriculum at Arcadia that I was looking for a research project, and I had to concentrate on a semester and something. And so I was able to do that, and at that point, women's health, pelvic health, and then I was able to do my research on diastasis recti abdominis, and it was like the perfect it was all meant to be. So anyway, if you would have asked me uh in 2010 if I was going to be a pelvic floor physical therapist, I'd say, no, I don't think so. So it basically chose me, and it is the missing piece of the puzzle. So my journey then started then, and I am passionate about what I do because, like I said, it is the missing piece of the puzzle. And being a physical therapist for 30 years now, I have been in a lot of other areas of physical therapy. So I look outside the box to look inside the box. So I just don't look within the pelvic box, and I look at the whole person because that's what we are. We are whole people. So that is basically how I got into physical therapy, or I mean, into pelvic health. And then after I had been working with women's health for a few years, then I decided that I was then going to sort of journey into male pelvic health as well. As I got my, my confidence and things like that. And so now I treat people of all genders, and I am thankful, and I feel it's like a privilege and an honor to work with these people.
So let's talk a little bit about the pelvis. If you can share something, because when a lot of people think about the pelvis, they just think about like their hip bones, and then nobody really realizes that there's a lot of muscles all throughout the pelvis, the pelvic wall, muscles on the inside. There's external muscles that also contribute to problems. So if you can share a little bit about the anatomy of the pelvis, that would be great.
Sure. Now, I don't know, Dr. K, can you hear me okay? Because you're
Yes.
breaking up a bit. Okay. All right. Fantastic. Okay. So, yeah, so the pelvic floor is a part of what we call the abdominal canister. So the bottom, if you imagine like your torso as an exercise ball that's a little bit peanut shaped, the top of that exercise ball is like the diaphragm. Bottom is our bony pelvis and our pelvic floor muscles. Sides and front are our abdominals, and they're like a tight fitted vest. And then we have the bony spine muscle and connective tissue in the back, and all areas need to work together in order to function because it's a pressure system. Um, but the pelvic diaphragm works with the respiratory diaphragm, works with the vocal diaphragm. So we have like sort of like this pressure system that's like, as Mary Massery would say, like sort of like a soda bottle that we or a soda can that is like it's a pressure system between our different diaphragms. The pelvic floor has three layers. Um, and that's three muscular layers, but we also sort of have the hammocks and the bungee cords that help suspend our organs to make sure that within this abdominal canister, to make sure that everything is able to move and groove, but able to hold its space so that everything is just not piled at the bottom like socks in a laundry bin type of thing. Um, but the pelvic floor again has the three layers. So we have the outside layer, um, we have a middle layer, and the outside and the middle layer, they are more of the contraction layers. They're the ones that sort of like, stop the flow of urine, so that we stop if we have gas, so that, and but those areas also have to relax in order so urine can come out, so that stool can come out, so that with sexual activity. We have a deeper layer called the levator ani, and that layer is the lifter. Like that's levator. It's like a lifter, and that so the pelvic floor function. Like if you hear of a Kegel, um, that is more than just tighten pelvic floor. It's like a tighten and a lift. Um, so that is, you have your muscle, but you have a lot of connective tissue there, and your muscle and your connective tissue work very closely with hip musculature too. So if we talk about the pelvic floor muscles, we really also need to talk about the hip muscles too, and the abdominal muscles and the back muscles. So everything is interconnected, but especially like our deeper hip rotators, actually the deep pelvic floor, that levator ani, one of the muscles actually holds on to one of the hip muscles. So if you have hip um, issues with mobility, you likely will also have some issues with pelvic floor and vice versa. So it's not just working with the muscle, it's working with that sort of that net that covers all of the cells, all the muscles, gives them their form and their shape, that fascia. And that's a connective network within the whole body.
Hmm. When I speak to patients and I'll say to them, okay, your clinical presentation allows me to say, listen, I need you to go to pelvic floor physical therapy. And they'll say, well, I'll do my Kegels sometime. And I try to explain, like, there's more than just doing a Kegel exercise. Kegel exercise just isn't your answer to end all for pelvic therapy, because a lot of times they feel like, well, my doctor told me to do Kegels, so I should be fine. I'm like, you're not. You have to really go deeper than that. No pun intended, right?
Right,
So
exactly.
right. It's just, because I don't think they understand that there's, like you said, there's strengthening, there's lengthening. There's things that need to be done by a pelvic floor physical therapist that you're not going to do on your own. Right. So
Well,
that's
if
why
I
it's important.
yeah, well, if I can make a comment about the Kegels. So, um, out of out of everyone that has come to me that has done Kegels, I would have to say that I could probably put in the palm of my hand how many people actually were doing them properly. So a lot of times it's an area of our body, pelvic floor is an area of our body that we typically are not as in tuned with. So, like, if I ask you to do a bicep curl, like, I'm very familiar with my biceps. I know when it's bent, I know when it's stretched, right? But with pelvic floor, like, that's a very much has like for most of us has been like a very like sort of automatic area of our body, and we don't really think as closely, or we don't have as much of a connection. So when I say that, when I with Kegel, and ask people to show me, okay, well, show me how you've been doing the Kegel. In all honesty, they've been compensating with either their glutes, their buttocks muscles, the muscles on the inside of their thighs. They and the pelvic floor is not functioning at all. So when we compensate with a lot of those outside muscles, what I like to call the neighbors, when the neighbors or the nosy neighbors are trying to help out, the ones in the pelvic home are really not doing a whole lot. So, or if anything, and one nice thing that I heard you say, Dr. K, is when you were saying about lengthening, our muscles work at the optimal length and tension. So, and again, I know I'm just sort of like explaining from a pelvic
Mhm.
health standpoint. I know you know all this, but so the proteins in the muscles that actin and myosin, they're made to function at sort of like a Goldilocks length. So that means like sort of like not too short, not too long, just right. So um if a muscle is too tight, and if I just show you with my fingers, well, is this, will this be on, I don't know, is this a video as well, right?
Yeah, yep, we can
Yeah,
see it.
okay. Yeah.
Sure.
So if your muscles are too tight, so these are different proteins, well, they can't generate force, right? So if, oh, like most of us hold a lot of tension somewhere in our body, and in all honesty, a lot of us hold a lot of tension in pelvic floor, those muscles are not able to generate the power that they need to. Now, if a muscle is too stretched out, the muscle can't function either. So the proteins have to be lined up nicely in these cross bridges so that they can both contract and they can relax. So sometimes in order to get someone to have their pelvic floor functioning, we actually have in a lot of times we have to get their pelvic floor lengthened or stretched enough so that it is able to contract properly. But not only are we talking about the muscle, but we're talking about that net around it. And I like to use the example, like if you have onions in an onion bag.
Yep.
So the onions are like your muscle, and the onion bag is like your fascia or your connective tissue. So if I have those onions in a bag and I hold it tightly at the top, the m- the onions can't roll around in the bag. Well, the same thing with a muscle. If the bag or the covering of it, the fascia, is too tight, the muscle can't function properly either. So a lot of times I work with the pelvic floor and the hip and the back and the abdominals to try to lengthen that fascia to also allow then to allow it to be able to contract properly. Does that make
Yeah,
sense?
perfect sense, perfect sense. I mean,
Mhm.
in my world, from the manual aspect of things, when we're dealing with fascia, I often say it's like looking at a spider web. If we pull down just on the bottom of that spider web, everything that's connected to it is involved, right? So
Ex
it's all interconnected. From
Absolutely.
movement to breath, to tissue, it's all just interwoven together. Like you said in the beginning, it's not just this pelvis, it's the person, right? It's the whole person, you know.
If somebody comes to me with pelvic health related issues, I'm asking them about, um, do they have they had surgeries, and if they have a breast surgery, or they may have had the thyroidectomy, or they may have had a cervical fusion, or they may have had back surgery. I'm working on that scar. I'm working on the fascia and the connective tissue there as it affects pelvic, and because you work there and they're like, you're working that far away, and they're like, "Well, wait, that's actually, I can feel that where I'm feeling the pain." Yeah, you actually can, And an interesting part about this connective tissue is with again, male pelvic health, the as we grow in utero, with someone who has a, and I shouldn't say male, someone who is born with a penis, the their testicles are up more in the abdominal wall, and as they descend through this like fascia or this
Mhm.
connective tissue in the abdominal wall. So the abdominal fascia is so closely related to not only testicular or scrotal issues, but also penile issues and pelvic floor issues. So that is an area, the abdominal fascia, that it's just like sort of like first place to go to look. And then, and, you put with some people, maybe they had a prostatectomy, maybe they had an umbilical hernia, maybe they had an inguinal hernia. And then there's all that scar tissue there too. So I guess again, what I'm saying is the fascia, connective tissue, and also length of those muscles. That is, and again, we're not just looking at the pelvic muscles, we're
Right.
looking in that, in the whole body, how they are relating. And another, I guess, if I can just say this, um, so we're talking about, and I'm just going to tilt my camera a little bit. So with the respiratory diaphragm being more like right here,
Mhm.
then we're talking about if someone has a very closed posture, forward head, forward shoulders, they're not able to expand that area. And we need the ribs to be able to expand to get the diaphragm to expand. Diaphragm and your pelvic floor, they work together. They need to work together. But again, through that diaphragm comes that very important, wonderful nerve that you and I have discussed before, Dr. K,
Yep.
that wanderer, the vagus nerve that helps us de-stress, rest, digest, and helps us relax tight muscles. So again, we're looking at how at that whole connection, but if someone's posture, we need to look at that too, because that can directly and indirectly affect how pelvic floor functions.
Right. So, like in the functional medicine world, we still go through that neuromusculoskeletal exam, right? So we're
Mhm.
still looking at that forward head posture because yes, they may come in with an IBS complaint, an irritable bowel syndrome complaint. We get that, but you look how they're holding themselves. You look at their posture. You look at their breathing, and we see the common complaint that we'll hear often is this abdominal distension. I feel bloated. Now, sometimes
Mhm.
the bloating feeling is related to the food that they're eating. So they'll stop eating food, but they'll still feel bloated when really it's related to the pelvic floor and the abdominal cavity. So it's not, you can take all the probiotics you want and have all the special testing, which is good, but we still have to get to that physical aspect of things where that bloating sensation can be directly related to the pelvic floor.
Yes, and also the abdominal lymphatics too. So maybe there's and lymphatics, so you have your circulatory system, which is your, with your blood to and from the heart, to and from the body. But then you also have the lymphatic system, that is that other drainage, like that. There's just these
Mhm.
tubules everywhere, and that's right underneath the skin. Sometimes they need to be facilitated. Um, and that can help the bloating as well. Or sometimes, when we spoke earlier and I was talking about that, um, the pelvic muscles and the hammocks and the bungee cords that hold the organs within the abdominal cavity. Sometimes those bungee cords and those hammocks get a little tight and maybe don't move and groove, and then it's sort of like when the stool is coming around, it's more of a traffic jam. So, or if you're walking on a trail and it is there's a lot of brush, like, so there's a lot of extra branches and it hasn't been cleared. um it's harder to get through, it takes longer to get through. So you sometimes have to help clear the brush and help so that there's more flexibility in that area so that it's easier to journey through. And when I'm saying easier to journey through, I'm saying digested material.
Mm.
And because we know that in the colon, that last journey, the role of of the colon is to keep pulling water out. So people may be coming with constipation
Hmm.
and they're or this bloating, but the journey is taking longer. And yes, they're taking their pre and probiotics, they're watching with what they're eating, all that wonderful thing, but things are not moving and grooving so that it's taking longer in that colon and more fluid gets pulled out. Well, then it's harder to get it out. And the outlet is the pelvic floor. And if it's hard to push material through there, what does our body do? It protects us and it tightens even more.
Right.
So,
And then there's that heavy psychological component to it. It's like, I didn't go today. Okay, I didn't go the day before. I didn't go the day before, and you're tightening up even more, and you're afraid that
yes,
every time you go to the toilet, you can't push because you can easily get an internal and external hemorrhoid by pushing. So we don't want anybody pushing. So
right.
the constipation, we often ask them like, is it that you're going daily and you don't feel like you're fully evacuating, or you're going, but it's more like pellet size, or there's not even the feeling of starting to want to go, right? So there's those folks who just there's no motility factor, right? There's nothing to even start it to going, and they complain that bloating, so they end up taking more fiber, but with more fiber, they bloat even more.
Yep.
So doc said, conventional medicine, like, let's give you Miralax. Okay, it's great, but it still didn't start the system of going where, like you said, addressing the lymphatics, the abdominal lymphatics is so important. That's why sometimes we even talk about belly massage. So it's not always
Yep.
related to food. That's why, again, where I feel pelvic floor physical therapy plays such a strong role in that irritable bowel presentation. Even with SIBO, the small intestinal bacterial overgrowth, I think
Oh,
pelvic floor
yes.
physical therapy plays a huge role, right? So if you're blowing high on hydrogen sulfide, blowing high on methane, hydrogen sulfide is more related to diarrhea. We still have to address that pelvic floor because we're missing, I think, a very important component to that presentation.
I agree. But the first place I would go, um, and I don't think anybody leaves leaves the office. I always say if you leave me with one important thing, it's going to be the breath. It's going to be the breath because your breath is and again, it's not, oh, take a deep breath, because a lot of people, what, they take a breath right from up in their upper chest, and we don't get that diaphragm moving, we don't get those ribs moving, and then we're not able to stimulate vagus nerve. So with the vagus nerve, I think that is like that's an absolute. Like, we have to make sure that we're looking at the function of the vagus nerve, and to make sure that it can function properly, so that it can help us with that motility, you know? So there's something called visceral mobilization. So I work with that as well, and that's when we work with how again, with those bungee cords, with the hammocks, with the connective tissue deeper around the organs, and it's very gentle, but that can also help stimulate things, to want to journey through, right?
Correct. And it's hard though to find visceral manipulation, right? I mean, there's not a lot of you folks around, so we
Yeah,
want we need more visceral manipulation, and it's not always easy to find. Um,
no, and pelvic practitioners are more difficult to find. There's not a lot of us out there. And I think a part of it is when you learn to be a pelvic practitioner, you are both the patient and the therapist when you're learning. So when I first start learning pelvic, we were in I think my pelvic floor 1 class was um like 100 people, 100 practitioners, 100 therapists, and then, like, so there could be, you know, 50 50 people that are patients, 50 people that are playing the therapist, but then you then go to the next partner, the next one, so that you can understand, because everybody is so different. So I
Mhm.
think that that might be a little bit of a deterrent for some people to get into pelvic health.
Right.
However, that helps us empathize, so there's nothing that we're going to be doing with anyone that, A, we haven't had done to ourselves
Right.
by not just one person, but by a lot of practitioners learning, you know?
I don't think the general public realizes like what we go through as practitioners when we're learning to become a practitioner. I mean,
Right.
so
Absolutely.
you know, it sounds weird, but in the state of California where I was licensed, I mean, at the time we had to do so many gynecological exams, so many prostate exams, so many breast exams, because they wanted to make sure, like, you knew what was not within your scope and when to send it out and who to send it to, right? So
Right.
again, you
Yeah.
have to practice on someone. So, yeah, I mean, I think that gives you that little bit of empathy as well, right? So I think that's,
A lot of it.
right.
Yes,
So,
absolutely. And I think that, well, one thing I know is it's not an easy, appointment to go to for pelvic
right.
health. Um, so we need to really understand that and really give the individuals that we're serving our 100% to be able, so that they know we're meeting them where they are. It's so hard to talk about all the different questions. I mean, when people come in and I try to make them feel comfortable, I let all of my people know, I mean, they're the captain of their ship. I'm here to help them steer it. I say that with everyone. I said, because I mean it, you know. Um, and the idea is to help build people's toolbox, and so that they can open it and get them to a point that they're able to open their toolbox, dust some things, dust a tool off, and be able to use it to be able to help them, Dr. K, you and I had talked about too, like you were saying, uh with someone, having that like anxiety about not being able to have a bowel movement or something
Mhm.
like that. And that whole and it's just not with bowel movements, it's just not, it can be with pain, it can be with a lot of things that people deal with, but it's that anticipation when something shows up again or shows up, that it starts that whole response, that
Mhm.
that whole connection with the brain, and it can really, influence how our body reacts to that versus how we respond to that. So I think that that is also not just important with pelvic health, but as you and I have talked in previously, just with with all of us, so that we can help our bodies respond to a situation versus how our body automatically, the cave person brain of us wants to react to it.
Right. And we'll see that in the functional medicine world, where somebody will have a flare up and it could be, usually gastrointestinal, and it's like, oh my God, it's nothing's working. It's all coming back again. I feel all the pain again. And it's like, nope, let's take a step back. Let's open up the toolbox. You saw what happened. Let's put out a couple of tools, what we need to use, and you move
Yep,
forward. You're not going backwards. It's just a flare, right? So we want to bring that anxiety down. And we see that so much anxiety when it comes to the gut. We really see a lot of that when it comes to pelvic issues, because again, at least you're creating an environment where it's welcoming. Sometimes it's hard to talk about the issues, right? Especially around the pelvic.
absolutely.
An injury. So if you remember in the 70s, the sliding board, you come down, you hit your coccyx, right? It wasn't a smooth transition like it is today, right? So 60s and 70s, you go down the sliding board, boom, coccygeal injuries, pelvic floor injuries, right? So you can talk about an injury to the pelvis in that perspective. Injury to the pelvis, a slip and fall, motor vehicle accidents. Because when we see motor vehicle accidents, there are pelvic injuries. Even when they don't think there is, they don't realize there is until we find out, and we got to get them to the right people like yourself. But when it comes around to pelvis, and it's like, it hurts to have sex. It hurts to urinate. It hurts to move my bowels. So I've heard people say to me, it feels like just like cat's claws are just scratching at them. So let's talk, if we can, a little bit around, it hurts during sexual performance, and we hear that both from male side. You can hear that where they could have pain upon ejaculation, and of course on the female side of things as well. So how do you address those issues?
So we work on many different facets. We work on that. So try to see what the driver is. When do these symptoms start? How do they start? So maybe it's a positional thing. Maybe it's even like a postcoital or like after intercourse that maybe someone with a penis has some pain, or they may have pain deep in pelvic floor in their scrotal region, or they may have it right up like above where they're so like right up in this region too. So they may even have it like right above their pubic bone as well. So it could be for them. We're trying to find out when, how, is it positional? Is it after? Is it during? With a someone with a vagina, we may be talking. We may be looking at hydration. We may be looking at oral hydration, which is also important to gut health as well, which I wanted to mention earlier. But what we're putting in, look at the vaginal hydration. Maybe they need, and I like to say, like, sort of like we use chapstick for these lips. Well, sometimes we need chapstick for for those lips too. So, what kind of hydration do we need there? Is the tissue right around that area very sensitive? Like if we use a cotton swab, what we call a cotton swab test, to check for like vestibulodynia or vulvodynia, and that's like within the lips of the labia. That area that would be like more of our vulva region, but right deeper within the vaginal opening, that's more of your vestibule, and you could have some just like just with a very light touch. Well, is it a hydration issue? Is it a tissue issue? Is it a nerve issue? We would then look at the muscles. So then again, we were talking about those 3 different layers of muscles. We check all those different layers from the outside. I mean, well, we can only reach 1 layer from the outside, and then with a gloved hand, I would check the second layer and then the deeper layer. Um, but then we'd also be looking at the connective tissue. We may also be looking to see how the nerves are gliding. There's a you've heard of pudendal neuralgia. That nerve um, really innervates and supplies that pelvic region. Well, that might be very inflamed. So we would work with and again, everybody is like an onion. They have a lot of layers. You just start to look at the person, ask a lot of questions, keep asking yourself questions, and it's like a detective to then try to like you're solving the mystery one layer at a time.
Gotcha. So if we can talk a little bit about PCOS, do you see patients with PCOS?
Absolutely, yes.
And endometriosis. So
Yes.
that's two of the common ones we'll see come in the office. So from our perspective, with our PCOS patients, a lot of times, hopefully, they'll be prescribed metformin because that's helpful. And then we'll support it with B12 because metformin beats up the B12 a little bit. And then there's the aspect of their nutrition. So because we really want to keep that sugar very low, carbohydrate very low. But then there's the role that you play. So, there's what we can do on our side, and then can you talk about how you can play a role with that PCOS and what they present with?
Again, with PCOS, which is polycystic ovarian syndrome, right? Uh, we are looking at again outside and with inside that abdominal canister, and what may be functioning. So they may have a reduction of like mobility of the fascia, both on the outside. They may have tension in the abdominal wall from all the pain. Pelvic floor, they may have the tension and the pain within the pelvic floor. It might be the connective tissue, but then it also may be how things are moving. Again, that on that visceral component, or on those, or how organs are sort of gliding and moving. Same thing with endometriosis, as far as uh, have they had the diagnostics? Have they had an excision? Have they had treatment, an ablation versus an excision? Where is the endometriosis? And endometriosis can cause a lot of scarring, right? So, and a lot of pain. But
Mhm.
again, no, I'm not going to say but, and with all traumatic experiences, and these things are trauma because a lot of times these individuals have been going from practitioner to practitioner to practitioner, or because or they've been told for a long time, well, it's normal, or they'll say, oh, you just have painful periods, or you know well, someone with PCOS, well, why, I'm not able to, with all these other hormonal issues that happen with PCOS, uh, and not finding clinicians to be able to help do diagnostics, right?
Mhm.
And to be able to explain why they're having this pain. Again, with PCOS, with endometriosis, it becomes then a traumatic experience, and the brain remembers, right? The
Mhm.
body keeps a score, right? So,
Okay.
so that is also important, and that's also essential for us to look at as pelvic health and abdominal wall clinicians. Um, Sort of their experience, their journey, and to really validate them and to really be appreciative that they're showing up, and to try to help them change that narrative, that brain narrative. Again, we don't just do that by ourselves, but we can help them get other clinicians on board as well, to help with the mental wellness aspect of it, because it's trauma. It's trauma.
Right. Right. I sometimes say, Paige, it's not all in your head, it's in your pelvis, because
Or it's in
a
your
lot of time.
brain. It's
Right,
like our brain,
in
yeah,
the
and
brain.
our brain or it's not in your head. I'll tell people, it's
Right.
not in your brain. And
Right.
our brain receives signals, and it's up to our brain then to not only interpret, but to process signals, and amplitude of signals, right? So with and sometimes stimulus from a different part of the body that maybe, instead of talking like you and I, might sound like talking through a megaphone. It just may be so amplified because of it's a body's it's our body's response. Some of our nerves are more sensitive, become very extra sensitive. It doesn't mean that you're sensitive. It means the nerves are irritated. They're irritable. So how do we down regulate those nerves and also help the brain? There's a whole chronic, like with chronic pain.
Mhm.
Uh, there's a whole, like with the uh, with with central sensitization and what we call peripheral sensitization, how the brain and how the nerves um, process chronic pain or chronic stressors, and how that affects both the irritability of the nerve, the responsiveness of the nerves, but also the chemicals that our brain release. So whether we call that, like, the wet brain, dry brain, meaning, like, do we want to try to get our brain to release those neurotransmitters that are very calming, inhibitory, versus more of the upregulating, so that so that we feel things more, right? So again, I, I guess I don't mean to get off topic, but in order to talk about pelvic floor, we have to talk about all this as well.
Right. Well, I think if we didn't talk about it, then we're missing a great point, right? Because it's not
Yeah,
just,
yeah, yeah, yeah.
it's not just, come in for the pelvic floor treatment, out the door you go, right? We're not throwing a hot pack and you're done, right? So yeah,
No.
I think it's much, much more intricate. Butler's work it talks a lot about that pain. He has
Yes.
a great book, Explain Pain. They
Yes.
talk a lot about that presentation, how our
Mosley.
brain
Right.
plays, yeah, Mosley and all that. The neuroplasticity. I think if we didn't talk about that, we'd be missing a very large point, especially because you work with chronic pain, I work with chronic pain, so that's very important. And I think the chronic pain patient often feels, beat up, and sometimes they feel, it's left out there just on their own to try to find help other than medicine. It's not that
Right.
medicine's bad. It's not. Medicine is fine, but as you well know, there's a lot of things that come along with taking pain medicine for long periods of time, especially opiate induced constipation, which is just huge, right? So, from your perspective, my perspective, that manual work, that brain work is extremely important. So I think you cannot not talk about it. So no,
No,
wonderful.
you can't talk right. You can't talk about one without the other because
Exactly.
everything is so interconnected. And a person is a whole person.
Sure, sure. We're not treating just the shoulder, we're not treating just the pelvis, not treating just the back, not just the gut. It's the person.
Yeah.
But and that leads me into a lot of the male mindset when it comes to their health, right? So I don't think they get concerned when they feel down below is going to be compromised, and then now they're concerned about their health, right? So they don't realize again, and maybe I don't know how many internists realize like, hey, that prostate issue can be addressed also from a pelvic floor perspective, right? Or that bladder issue. And we know patients like that, and it's important. I think that gets translated. Pain upon ejaculation. And I don't think a lot of you know a lot of men understand how they can come to pelvic floor physical therapy and actually improve.
Yes. And so the with someone with a penis, if they when they come for therapy, I am not working like right on their penile organ, right? So a lot of times because the whether you have a penis or a vagina, your pelvic floor is actually very, very similar. Muscles that would go around the labia, around the opening for a woman, for someone with a vagina, that will come up under the base of the penis on someone with a penis. So the the pelvic floor is very similar. So I will have that individual sort of like move I'll say, can you move everything up and over to the left hand side because I'm going to work around underneath that area, but might not be directly on that area. So if there is some sort of mobility with fascia that I need to do, like around the penile region, a lot of times I'll be working underneath, and if they need to do the mobility, I have them do that. It is definitely um again, and I was talking to my daughter about this actually yesterday because we were talking. She says, I have a almost 20-year-old and a 23-year-old, and they're like, Mom, you do really, really, really cool work, right? So they both told me that yesterday, which is always nice when your kids tell you that. But
Right.
we were talking, and I said it's trying to make someone feel comfortable that has a penis, that you are not going to be in their business, right? And to then still be talking about the weather or what they're doing, like over the weekend, as I say, okay, can you just move up everything up and over to the left? And we keep things very professional, and I am just working on the pelvic muscles, the connective tissue, and I'm really it is not it is sort of so separate from any kind of what uh people would expect if you're working in that region. So it is we keep things very comfortable but very professional, and they're doing the work with that end. And I will be working maybe right above their pubic bone. I'll be working on their abdominal fascia. I may be working right around all of that area, but it's done in a way that is very comfortable. But everyone has I and I'm it's ongoing consent. So I let everybody know, "Okay, I'm just gonna move my hands right here. Is that okay with you?" And I wait for them to say, "Yes, that's fine." "Okay, I'm gonna work in this area and I'll grab the model, the pelvic model. This is where I'm going right now and this is why. Is that okay with you?" So it's not like I'm pulling a quick one as far as like, "Oh, now I'm going to be putting my hand someplace that they're not expecting," because there's like ongoing not only consent but in information. I let them know what I'm finding, so that they can understand as well.
Excellent. Thank you for sharing that, because I think a lot of people are apprehensive because they don't know what to expect.
Yes. Yes.
So I think that's great. That was a wonderful explanation. So when somebody comes to you for the first time, what do you do? What does your exam look like and intake and all that?
So I work for Lehigh Valley Health Network. So we have, I before someone comes in, I'm doing a thorough chart review, what testing that they've had, doctors that they've seen, healthcare professionals that they've seen, whatever I can, labs. I'm looking at all of that, their history. They come in, I let them know again, I know this wasn't an easy appointment for you to come to. You are the captain of your ship here. Again, I don't say that just to say it. Um, I said, I'm going to let you know what I know, and then I want you to help fill things in for me. So then I give them sort of like this is what I'm seeing. So now you tell me why anything that I'm missing, fill in some blanks, explain to me. So then they talk to me about that. I ask them about their bladder function, bowel function, pelvic pressure or prolapse issues. And we can't, if we have time, we can talk about that. Um, and then also sexual function. And, if they're not sexually active, why? Is it like a partner? Is it a choice? Is it because of pain? Is it because of embarrassment because there's leakage or something like that? So I ask a lot of questions regarding that. I always do a general orthopedic assessment. I check for posture, mobility of the back, neck, upper extremities, lower extremities. I check um, pelvic alignment, in standing, lying down, hip mobility, abdominals. I check the distance between left and right side of our abdominal vest to see if they have, again, what's called the diastasis recti abdominis. I check their breathing, how their ribs are moving, and maybe the first visit, a lot of times, I'll have time to do a pelvic muscle assessment if it's indicated. I will tell you, I've had several people that have come with bowel or bladder dysfunction that are like, "No, I don't want any pelvic. I don't want
Hmm.
I don't want you near that area." And then I'm like, "Okay, so we'll find another way." So I have to. I'll say, sometimes I'll say, "May I check the muscles from the outside over your clothing?" Sometimes they say yes, sometimes they say no. And maybe they say no, and then a couple visits later, they're like, "Okay, you can check those muscles now." Okay, great. We do that. But if not, then I have to then see what's going on the rest of the canister, make some assumptions, but I can often check with how the hips are moving, what might be tight. Um, and then we work to try to lengthen muscles, and then we might, then I work with everybody differently. So that first visit may look really different for different people. Sometimes this week I've seen a lot of new people. Some people may have so much to sort of unpack that first visit. And we do a lot of talking that first visit, and we do what we need to objectively, like with assessment. And then there's always the next visit to take care of what we didn't get to. For some people, I'm able to do a lot of hands on the first time. Um, but for some people, a part of their healing is being able to, they have a lot to discuss. They have a very complicated history, and I want to respect that as well. So the visit might look different, but it always has um, ongoing consent with both asking the questions. I ask about trauma. I ask if someone has, depending, I try to ask their relationship with food, and also have they had a history of maybe restricting or binging or purging, because that can play a big in impact on bowel bladder, sexual function, anxiety, and that kind of thing. And that's something we need to know.
And typically you would see somebody once a week, once every other week, because I mean it's pretty deep work, no pun intended. But
Yeah,
it can be very emotional. I'm sure that sometimes there's
yeah,
emotional release as well.
a
Um,
lot. Yes.
right, there's the physical changes. So I'm just hard pressed to see. Oh, you're going to see somebody 3 times a week. Um, yeah.
No.
So you typically see like a once a week, once every other week.
So it depends on the clinician, like with our network. Like to do in sort of like in my like wish book, like like you remember the Sears wish book for the holidays or whatever, right? So in my wish book, I would love to be able to see someone every week for the first month, then maybe every other week, and then maybe once a month after that. But for some people, maybe they can't get in, or maybe with scheduling their schedule, my schedule, maybe it's every couple weeks. Um, it depends on the person. There are some people that I only see for a couple visits. There are some people that I see for much longer than that. And it all depends. So, no, they're not going to be coming in more than once a week for sure. And if we're able to get them in once a week, initially, that's really fantastic. But that doesn't happen for everyone. And it all depends on the person. So their visits with me are an hour, like between 50 minutes and an hour. With me, typically like right on the hour because I try to use every minute. Um, but that includes hands-on work. But that also includes us problem solving into their everyday activities, education, that home program. They will never come to me and get 3 sets of 10 of any exercise. I so I will, with activities or with exercise, exercise. I will um often have spot check things and then say, okay, yes, you're doing that, or let's tweak this a little bit, or let's use this into your everyday. Okay, how are you lifting your baby? How are you getting the stroller into the car? Like, I
Mm,
deal with a lot of obstetric patients too. So I during pregnancy and postpartum. So that is a huge portion
mhm.
of the people that I see as well. But whether I just had a gentleman post prostatectomy. He does a lot of manual work, so we are working with how he's going up and down ladders, and pressure management, how that affects leakage. So how often, it depends on the person. What is included depends on how their onion is and how we have to unwrap those layers.
Right, beautiful. All right, so before we get into the next topic, so we'll just give a rundown of if we think things that where a pelvic floor physical therapist can help, and there's so many things. So bladder issues, urologic issues, painful
Yes.
urination, incontinence. Um, they'll say my stream isn't strong, prostate issues, current or after a prostatectomy, erectile dysfunction. That's something else that you guys also take a look at. Um, endometriosis, polycystic ovarian syndrome, during pregnancy, post pregnancy, lacerations, injury to the pelvis floor. What else do we have? Did we cover everything?
No, well,
What am
like
I
a
missing?
lot of constipation,
Constipation,
difficulty with
bloating,
bloating, difficult with evacuation,
pain during
fe
sex, intercourse,
yeah,
or
fecal
floor pain.
incontinence. I work with a lot of people with fecal incontinence, people with pelvic organ prolapse. That could either happen vaginally, that and prolapse is actually like, sort of the leaning of those organs onto different areas of the vaginal wall. It could be like the front, the back, or actually the top. Whether their cervix and their uterus are low, or maybe they had their uterus removed, but now sort of those bungee cords that helped hold that vaginal vault up to different areas in the like in the pelvis might be down lower. So we I work with a lot of people with pelvic organ prolapse, pelvic pressure, pain during intercourse, pain after intercourse, just pain in the tailbone, the pelvic girdle, which is like, your listeners will have heard like your SI pain or that
Mhm.
sacroiliac joint pain, pubic symphysis pain, which is in the front of the pelvis. With people with a penis, it might be testicular elevation. It might be pain in a testicle, abdominal wall pain. I see a lot of people after abdominal surgery. Um, uh, gosh, I know that I'm missing,
Yeah,
I'm
because
sure a lot of things that
right.
we
I mean,
see, but we could go
VQ.
on and on.
Right, right, and that's the thing. And the reason I asked that question is because I think a lot of people don't realize that these symptoms can be addressed with pelvic floor physical therapy. That's why I'm a huge fan of that. So
Yeah.
the next section with pelvic floor physical therapy I want to get into is that emotional aspect of it, right? So
Mhm.
we're going to make this jump so everybody can understand if there was injury, if there's pain, they get that. But let's talk a little bit about that tie-in of the emotion and pelvis.
So, especially someone who has, let's say, pain with intercourse. So, I'll say an example that I give to someone is, if you're a lovely person, I said, but if I walk through this door and you pop me in through the nose, like pop me in the nose, and then I come into to this room again, and the next time you pop me in the nose, even though you're a wonderful person, about the third or fourth time I come down the hall, I'm going to be 10 up the hallway, be preparing that when I open this door, a pretty good chance that you're gonna be popping me in the nose. So the reason why I say that is because our body responds, and the emotional, and again, that brain-body connection. So even anticipating having intercourse, anticipating that experience, their body is already tightening up. So sometimes we have to work with sort of a variation of like a graded, well, it's not graded motor imagery, but it's like implicit and explicit like visualization that you go through the experience, trying to monitor, doing body scans, seeing what's showing up in your body, and then tension, and then using tools to try to relax that tension. And this is, you're not even having intercourse at this point. You're just thinking about it. And maybe it's when your partner sits next to you on the sofa and just puts their hand on, you're already tensing up. It's just becoming more aware of your body and what's showing up. So as far as that emotional component, we then work with how to how our body responds in those situations. And again, I'm just going with it with pain with intercourse. But go ahead. I'm sorry. Did I get off topic on that?
No, it's just I think a lot of people don't realize that, emotional storage can be built up in the pelvis, and that has to be addressed.
Absolutely. And yes, and again, one of the first we when we talked, we started, we were saying about how muscles have to work at the optimal length tension. Well, many of us are during different parts of the day, the whole day, or we then become more aware when our muscles are like this because they can't function for us like that. So yeah, it's like that the emotional tie to the pelvis is huge is and the pelvis actually sort of like has a brain of its own type of thing, and really because it's important for so many different things. It has so many roles. It's like your sphincter control, it's your sexual function, it's like a sump pump, it's stability and control. It is, I mean, our it's in it's it's so important for so many different things.
Yes, it is, and that's one of the things I wanted to bring, light to today is that I think it's often overlooked, and I think it's really, really important, and I'm really grateful for your time and sharing all the information that you shared with today. So my last question for you and is what book are you reading now? I always like to ask
What
people
book
what
am
book
I?
you're reading. Yeah,
So, I am not, I am actually reading, Sick Enough, and it's by Dr. Gaudiani. I'm designing a education for pelvic practitioners on eating disorders, and I'm reading her book, which is super fantastic, and it's helping me prepare for some of the information. I had the opportunity of interviewing her, and so that is a book that I'm reading right now, but actually have my hands in a lot of things right now. So
beautiful, excellent. So how can somebody get in touch with you?
if they can, well, my email is my work email is Carole, Carole dot Gross, Gross at lvhn.org. That but as if they contact if they want to schedule with me, they can contact LVHN. They would then get I work in the health center of Palmer in near Easton. That's where I work. Right now, my first available is a few months from now.
Mhm, mhm.
However, uh, once you're like sort of like on my schedule, we make things work. If it's a post-surgical thing, they need to let scheduling know that as well. And that's how, if someone has once to that we have wonderful clinicians in our area, in the Doylestown area. Um, there's wonderful places as well. Prior to being with LBHN, I was with Central Bucks Physical Therapy.
Very
I
good.
work with Kathy Sumner and Janet Drake Whalen. Janet's now with Grandview. Kathy is still at CBT. There's Core Three. There's wonderful uh, pelvic health clinicians there. So wherever you can get is wonderful. There are again, I just want to make sure people get the help that they need. You know.
Great. And I think today they did. I really, really thank you for your time today. It's great information. Any additional words of wisdom you want to share with us?
Um, you are like if I can speak to everyone that's listening, you are worth it. There are clinicians that care. that will be on your team. You will always be the captain, and you should always be respected as that. And if you're not, then maybe you're not at the right fit. Um, you want a clinician that looks at you as a whole person and not just as a within a certain box or within a certain silo. You want to look at someone that will work with your other healthcare providers, like Dr. K,
Mhm.
like you and I have with different people, and you want someone who wants to be a part of a team and doesn't want to just tell you what to do because you're the expert of you, and what you feel and what you're experiencing is number one real, is number one important, and is it is you deserve to be able to feel better.
Excellent. Beautiful. Those are beautiful
Yeah.
words of wisdom to leave us with. Thank you. Thank you so much.
Okay.
I really appreciate your time. Once again, this is Dr. Michael K from the Center of Functional Health. Today, I had the opportunity and honor to speak with Carole Gross. And you know what, folks? I'm probably going to have her back again because there's much more to cover. So thank you very much again. We'll speak to you soon.
Thanks for having me. Okay, bye-bye.